Welcome to our video on pneumonia. Let's get started. Here is our overview slide. Let's begin by discussing some general characteristics. Pneumonia is broadly defined as an inflammatory condition of the lungs that involves the lung parenchyma. The most common etiologies of pneumonia in pediatric patients vary by age. In the first month of life, the most common causes are group B strep or gram-negative enteric bacilli. In children younger than 5 years old, the most common causes are viral pathogens. Community-acquired pneumonia, or CAP, is most commonly due to strep pneumonia. Other common pathogens include Staph aureus and Moraxella catarrhalis. Atypical pneumonia is most commonly associated with Mycoplasma pneumoniae and Chlamydophila pneumoniae. The type of pneumonia depends on the type of pathogen. Typical bacterial pathogens usually result in lobar pneumonia. In contrast, viral pathogens and atypical pathogens result in bronchiolitis or interstitial pneumonitis. In neonates and infants, pneumonia may present as fever or lethargy. There may also be a history of periods of apnea. In older children, the presentation is more likely to involve fever, cough, and increased work of breathing. On physical exam, a provider may observe tachypnea, cough, and fever. In more severe cases, there may be associated hypoxia and respiratory failure. Auscultation may reveal a variety of abnormal lung sounds, including rales, wheezing, rhonchi, and decreased breath sounds. One unique sound that may be heard is a staccato cough, and this unique cough is associated with chlamydia trachomatis infections in infants. Like many of the other respiratory tract infections, pneumonia is typically a clinical diagnosis. However, laboratory and imaging studies can be helpful to establish an etiology or in cases where the diagnosis is unclear. If a patient is hospitalized due to pneumonia, blood and sputum cultures, as well as gram stains can be obtained in order to find the causative agent. Rapid viral testing should also be obtained to evaluate for a viral cause of pneumonia. One may also consider mycoplasma studies if there is suspicion for atypical pneumonia. Chest X-ray findings can vary in pneumonia. If there is a lobar consolidation on chest X-ray, a bacterial cause of pneumonia is more likely. In contrast, viral pneumonia will typically have a diffuse interstitial pattern on chest X-ray. When examining a child with potential pneumonia or other respiratory pathology, it's important to keep foreign body aspiration on the differential, especially if there was an acute onset of symptoms and if auscultation is asymmetric. Here are two chest X-rays to examine the imaging findings associated with bacterial and viral pneumonias. On the left is a chest X-ray in a case of bacterial pneumonia. At the top of the right lung, there is an area of patchy consolidation, which is typical of bacterial pneumonia. Now, let's contrast that to the X-ray on the right. And on this X-ray, we can see a case of viral pneumonia. Here, there is diffuse opacity in both lungs, which is very typical of a viral pneumonia. Most cases of pediatric pneumonia can be managed in the outpatient setting with supportive care and antimicrobials. Common antibiotic treatment options include amoxicillin, amoxicillin clavulanate, cephalosporins, and macrolides. If the patient has pneumonia due to influenza, they can start neuraminidase inhibitors. However, the preferred time frame for the administration of neuraminidase inhibitors is within 48 hours of symptom onset, so the patient has to be evaluated early in the disease course for these to be prescribed. Some neuraminidase inhibitors that can be used in the treatment of influenza include oseltamivir and zanamivir. Indications for hospitalization instead of outpatient treatment include significant tachypnea or hypoxia, a toxic appearance, and the inability to maintain hydration. Patients with a complicated pneumonia, for example, an abscess or a parapneumonic effusion, will also require hospitalization. Inpatient management of pediatric pneumonia begins with supportive care, including IV fluids, proper nutrition, antipyretics, and supplemental oxygen. Empiric antibiotics should be started as well. If the suspected etiology is strep pneumoniae, empiric antibiotics include ampicillin or a third-generation cephalosporin. However, if the suspected etiology is Staph aureus, empiric antibiotics include clindamycin or vancomycin. The treatment for pneumonia will typically last for 7 to 10 days. One positive characteristic of pediatric pneumonia is that many pathogens can be prevented with vaccination. There are vaccinations available against strep pneumoniae, Haemophilus influenza type B, and influenza. Here is a summary table of all of the topics covered on infections of the respiratory tract in pediatric patients. And in this video, you can see that we've covered pediatric pneumonia, and feel free to compare and contrast this with other conditions and watch the other videos on these other conditions as well. But as a summary, here is this table for your review, which should hopefully make this easier to master. All right, now that we've covered pediatric pneumonia, let's review with a final question. An 11-year-old boy is brought to the physician by his mother due to cough and fever for the last 4 days. Several of his classmates were ill with the same symptoms 1 week ago. His vital signs include a temperature of 38.1 degrees Celsius, a blood pressure of 120 over 80 millimeters of mercury, a heart rate of 91 beats per minute, and a respiratory rate of 15 breaths per minute. A rapid influenza test is positive, which is later confirmed with polymerase chain reaction. Other notable labs include a mildly elevated ESR. A chest X-ray reveals bilateral interstitial opacities. The medical student involved in this patient's care suggests initiation of oseltamivir, but the resident and attending choose not to administer this medication. The patient is also improving clinically. Which of the following is the most likely reason for not initiating the targeted therapy in this particular patient? A 4-day history of symptoms, B, stable vital signs, C, low-grade fever, or D, mild elevation of ESR. All right, this patient is presenting with a low-grade fever of 38.1 degrees Celsius and a cough. His rapid influenza test and the polymerase chain reaction test come back positive. The chest X-ray reveals bilateral interstitial opacities, and collectively, all of these findings are consistent with influenza pneumonia. The resident and attending choose not to administer oseltamivir to this patient. Although oseltamivir, which is a neuraminidase inhibitor, can shorten the duration of illness, its efficacy is well documented only if it's given within the first 48 hours of symptom onset. Therefore, the most likely reason for not initiating the targeted therapy in this patient is option A, a 4-day history of symptoms. Nevertheless, it's worth mentioning that if the patient had a severe refractory disease or if he was immunocompromised, then we would consider neuraminidase inhibitors even 48 hours after the onset of symptoms. Here we see the slide that we discussed earlier in the lecture, reminding us that neuraminidase inhibitors can be used in patients with influenza pneumonia, however, typically only if it's been less than 48 hours since the onset of symptoms. All right, let's discuss why the other options are incorrect. Options B, C, and D are incorrect because none of these factors affect the decision of not initiating oseltamivir as much as the duration of symptoms does. So again, the correct answer is option A. And that concludes this section.